theories. There aren't any that are specifically evidence-based at this point, or any that have been proven definitively. So to start off, just a quick reminder, because I am going to come back to this a little bit later, are the symptoms of depression. So looking at things such as depressed mood, diminished interest or pleasure in any activity, significant changes in weight, which may go in either direction, increases or decreases, changes in sleep, which again can go in either direction, psychomotor agitation or retardation, fatigue, feelings of worthlessness or guilt, impaired concentrations, and thoughts of death. And this may include some degree of suicidality. So keeping those in mind, a lot of the efficacy findings that we're going to talk about really are evaluating the changes in symptoms. So in going to the American Psychiatric Association's treatment guidelines for major depression, they are a little bit older, but they recommend the use of medications or psychotherapy, or a combination of psychotherapy and antidepressants together. These are recommended most strongly for those that have moderate to severe depression. For those that may have more mild depression, they do have some additional non-pharmacologic therapy. There's some interest in looking at increased physical activity, but our focus is going to be a little bit more on that moderate to severe end. There are a number of additional other treatments, such as elective convulsive therapy, transcranial magnetic stimulation, that also are recommended for patients who either are unwilling or unable to be able to engage in any of the other treatment modalities. So recognizing that the focus really is on medication, with antidepressants being one of the first-line treatment options, there are a few different phases of treatment that we could focus on. So the initial phase of treatment is called the acute phase, and that's 6 to 12 weeks. So the goal of this phase of treatment really is remission. Then there's the continuation phase, which is 4 months to 9 months, really with the goal of getting rid of any symptoms that are left and preventing any type of relapse of the symptoms. And then in the maintenance phase, it's 12 to 36 months with a goal of recurrence. So our focus is on the acute phase, because that's where some of the literature is going to focus on. That's where we have the most amount of data for depression. Recognizing that we need to have products that are FDA approved. The trials that are set up to fulfill the requirements of the FDA are that you enroll patients with depression, and then they're randomized to either go to the antidepressant, and sometimes there's more than one if they have an active control, or placebo. Now the active, we'll save that thought for the next slide. And then we're following them for outcomes. Now, why is this a big deal? Well, this is a big deal because we have a relatively large placebo effect for depression, and this is a little bit unusual. So placebo response rate, so the FDA requires that you prove that a medication is significantly better than nothing, and that's where the placebo came in. But if people are responding to the placebo, that makes it difficult to demonstrate that there's a difference. So you may actually have an antidepressant that's effective, but because the placebo or the no treatment was also shown to have some improvement in symptoms, that makes it really difficult. And the overall, so these are general review response rates. For antidepressants, it's considered about two-thirds of patients who are on antidepressants have response, whereas for placebo patients, it's about a third to over 40%. So a significant number, just under half, are actually responding to placebo. So that introduces the questions of, are placebos actually effective? Or what does that really mean for the antidepressant efficacy? And I had alluded to this on the last slide. It's really caused a large number of manufacturers to create a controlled arm. So having an existing approved antidepressant that's also compared to placebo, in the event that the placebo group has a really high response rate, that can kind of offset some of the thoughts that maybe this medication is not effective. So going back just a second, you see that antidepressant, sometimes that's split into two with the investigational drug as well as an existing therapy, which does increase costs for the manufacturers, but it can help address some of these concerns with the placebo response rates. So telling you that there's a significant placebo response rate, in general, I think I want to make sure you have the evidence to go back and support that. So in looking at two of the relatively newer antidepressants, because they included better data for the placebo groups. So this was a randomized double-blind placebo-controlled parallel group trial. It was 9 weeks long. It was placebo and duloxetine at 60 milligrams a day. Now, they were following the efficacy outcomes of the Hamilton Depression Rating Scale. So the two criteria that they used for response, it had to be at least a 50% reduction or more in the HAM-D, whereas remission, their total rating scale score had to be 7 or less. So for all of these patients at baseline, they were about a 21, so they were moderately depressed at that point. When we followed them out for 9 weeks, you can see in the bar graph on the left that the placebo group had a 29% response, so almost 30% of patients had a drop of 50% or more in their depression scores, symptom scores, and more than 15%, so 16% actually were in remission where they had minimal symptoms. So they had gone from having moderate depression over that 9 weeks to virtually having no symptoms whatsoever. So statistically, duloxetine did better, but there definitely was an effect seen in the placebo group. So looking at another trial, so this was also a randomized double-blind placebo-controlled trial. It was 8 weeks in duration. It looked at two different dosages of the vortioxetine as well as the duloxetine, and then that was compared to placebo. This one used a different rating scale, so the Montgomery-Åsberg rating scale, but similar, just being able to quantify the depressive symptoms that patients were experiencing. Again, response was a 50% or greater change from baseline, and remission was a score of less than 10. So these patients at baseline all had a score of average baseline score of 31. So they also were classified as being moderately depressed. And at the end of 8 weeks, again, we see that over 30% of the placebo group had responded. So their symptom scores had dropped by 50% or more, and almost 20% of these patients went into remission, where they had minimal symptoms that were present. So again, the antidepressant arms of this trial were statistically significantly better than the placebo group, but there still was a significant response that was seen with placebo. So why does this happen? And that's a great question. So we don't really know. There was an interesting article that was just published earlier this spring that looks at this specific question, and that's the Hengardner British Medical Journal Evidence-Based Medicine citation that's at the bottom. What they are postulating is that there's something called regression to the mean. So patients who are recruited for these trials tend to have really high depression scores. You want somebody that's moderately depressed so you have enough room to be able to see a change in their symptom scores. You're then going to follow these patients over time. So it does take some time for the antidepressants to work. So you're looking at usually at least 6 weeks, likely 8, maybe 12 weeks. And over that period of time, even if you didn't do anything, the suggestion is that those scores, those depression scores, would revert more downward in severity. So you would see a reduction in the amount of symptoms over time. Now, for the record, that wouldn't happen for everyone, but for the vast majority of patients, you would see something called regression to the mean. So down to what the average depression rating scale score would be for the general population. So that may be part of it. So maybe what we're seeing with the placebo groups is the regression to the mean that would just happen naturally over time. It's difficult to be able to prove that. Statistically, it does make sense. It doesn't hold true in all patients, but that may be one explanation for what we see. So that kind of introduces the question of, do we really need to have everyone on antidepressants? And is there a way to identify those patients that would be able to reduce their symptoms over time? And we don't have that information just yet. The other, one of the other reasons, which I think is interesting, is there is allowance of concomitant medications in the placebo groups. So for ethical reasons, if you have a patient who is very depressed, who may be randomized to placebo, there tend to be other medications that they can be given over time to help with some of their symptoms. Oftentimes it includes sleeping medications, a whole variety of sleeping medications. It can also include benzodiazepines. So things that may be helpful for anxiety or agitation. It may be helpful for some of their sleep issues. So some of these medications may actually show some improvement in those depressive symptom rating scores. Now, I will say with the response being a 50% reduction, I'm not sure that the concomitant medications can consistently bring the scores down that far. But for some of the older trials, response was improvement in 20% or 30% of symptoms, which may only be a couple points. So in those cases, that might be part of the reason that we do see improvement in this patient population. One of the other, I guess, intriguing factors that I was hoping to find additional information on, and I just found one kind of teaser study, is the psychological component. So is it an expectation that because you're enrolled in a trial, you're taking something that then you just will get better because you believe that you're taking something? And that could be in the role of the patients and or the role of the healthcare professionals as well. So there's an interesting trial that was done and just published in the Journal of Psychiatric Research. So it was a trial to examine the neural mediators of a patient's outcome expectancy. So they took 23 adults that had depression and they put them through a functional magnetic resonance imaging, so a functional MRI. So they wanted to see the inner workings of the brain. They were focused most specifically on the amygdala, which we know is involved in depression and mood overall. So they randomized these patients to either a high outcome expectancy, so it was a completely open label group, or a low outcome expectancy, which was a placebo controlled group. And then the intervention was citalopram daily for up to 8 weeks. So they did the functional MRI they did while patients were doing the facial emotional response test. Now, I am not a psychologist. I do not even pretend to be one at any point or time, but this particular test is showing patients different pictures of faces that are making different emotions. Some of the things that they look for related to that include emotional identification. So are they able to identify what that emotion is? It may be part of their emotional resiliency, so how much emotion they're able to experience. In some patients who are really depressed, they may have a diminished amount of affect or mood that they're able to experience. It also includes some of cognitive processing and word finding skills. So they would have to be able to identify the emotion and then come up with a descriptor that would be accurate for that. So that was the test that they had the patients doing while they were doing the fMRI. They did it before treatment, then they did it at the end of treatment. So at the end of those 8 weeks, and then they also took depression rating scale scores. So the results were that they found decreased activation in the left amygdala in the open label group. So with less activity in the amygdala, it was actually associated with less depressive symptoms. So really looking at, but if you looked at the depressive symptoms across the board between the two groups, there was no difference. So this group that was open label, who knew that they were taking an antidepressant, really expected there to be improvement. And they saw a decrease in the activation of that part of the brain. And then they actually had, it was associated with a decrease in those depressive symptoms. So this is really intriguing. because it tends to suggest that there is some suggestibility to how efficacious a particular intervention may be. It also tends to suggest that there really isn't a benefit necessarily for placebo, where there may be some patients who, if they know they might be on treatment or placebo, may not necessarily have different expectations. Their expectations may be lower because they may know that they're on nothing at all. So adding to some of the evidence, the authors do look to be doing a number of follow-up studies to try to build off these results, but it was really timely. It just came out in the last week. So I wanted to share those results with you. So overall, what does this mean? So depression symptom response to placebo is consistently reported. We see it in at least 30%, and it can be up to over 40% of patients that are being treated for depression. We're not exactly sure why that happens, but it is an effect that we know exists, at least in the acute phase. There's not as consistent evidence in the long-term phase. It may be partially due to just the patient's depression getting better on its own. It may be due to the other medications that they're taking, or it may be due to the expectations of the provider that, you're taking something, we would expect to see improvement, or the patient thinking that they're taking something to expect improvement. So in summary, I really think that this should encourage the consideration of all aspects of treatment. So if a patient believes that a medication is going to make them better, then that may be part of the initial response where they feel that they're taking steps to improve their symptoms. If it's something that potentially they're more interested in other aspects, there's a little bit of evidence coming out looking at physical activity, or there may be a psychological there may be a strong support for the psychological rationale, whatever the patient thinks would be better. Is there a way that we can incorporate that into treatment? Because maybe, just maybe, that can improve some of those depression symptoms overall. And that's what I have. I apologize for the background noise. I tried to find a quiet location.